Good day and welcome. My name is Katerina Tikhonova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of that treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. From that moment, you can start to prepare your plane ticket. Arranging your own translator. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника Лив, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники Лив желает вам благополучных дней.
Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Vadi, Istanbul. It is that moment which makes you hold on to life, sometimes near a forest, sometimes in daily life. With its advanced diagnostic and treatment methods, that moment actually represents the future. There are some moments which makes you look to the future confidently. Those moments are the future. Live Hospital, the future of healthcare, opened in Vadi, Istanbul.
В Вади, Истанбул, открылась больница будущего Live Hospital, отличающаяся опытом в уходе за пациентами и гостеприимным подходом к своим пациентам. Порой расположение на краю леса, порой в жизни наступит момент, когда продвинутые методы диагностики и лечения помогут вам выжить. Этот момент обязательно настанет. Есть моменты, когда вы начинаете смотреть в будущее с уверенностью. Так вот, это именно этот момент будущего. В Вади, Истанбул, открылась больница будущего Live Hospital.
Merhaba, ben Profesör Doktor Levhi Akın. 2014 yılından beri Live Hospital Ulus'tayım. Genel cerrahi ve cerrahi onkoloji uzmanıyım. Aynı zamanda Tıbbi Yürütme Kurulu üyesi olarak idari bir görev de yapmaktayım. Şimdi beraberce Live Hospital Ulus'un içine gireceğiz ve sizler için hastanenin ne kadar güvenli olduğunu gösterebilmek için birlikte bir hastane turu yapacağız. Güvenlik ünitemizi geçtikten sonra tarama bankomuza geliyoruz. Burada uzaktan ateş ölçümümüz yapılıyor. Daha sonra yakın özgeçmişimizle ilgili bir takım sorular sorularak kayda geçiriliyor. Taramamız tamamlandıktan sonra taramayı başarıyla tamamladığımıza dair yakamıza bir etiket iliştirilecek. Hastanede bulunduğumuz süre içinde bu etiketi sürekli yakamızda taşıyoruz. Buyurun. Evet, içeri girdikten sonra önce danışmaya giriyoruz. Burada görmüş olduğunuz gibi sosyal mesafe kuralları açısından gerekli önlemlerimiz alınmış durumda. Girişten itibaren sarı çizgilerimizi devam ettiğiniz zaman onkoloji hastalarımız için özel olarak tahsis edilmiş olan asansörümüze ulaşıyorsunuz. Öncelikle şunu ifade etmek istiyorum. Bizler için en önemli olan şey sizlerin ve hastane çalışanlarımızın güvenliği. Biz sizlerin sağlığı ve tedavisi için buradayız ve hizmete hazırız. Misafirlerimize açık alanlarda ve bekleme bölümlerinde bir takım tedbirler aldık. Gördüğünüz gibi sosyal mesafe kurallarına uyabilmek için işaret gördüğünüz alanlara oturulmuyor, diğer alanlara oturuluyor. Oturulan alanlar her yarım saatte bir temizlik personeli tarafından siliniyor ve temizleniyor. Hastanemizde gerek hastalar, gerek ziyaretçiler, gerekse de refakatçilerle birlikte tüm hastane çalışanları için maske takılması zorunludur. Şimdi bir hasta muayene odasını birlikte göreceğiz. Zaten hep temiz olan yerler. Fakat bu dönemde biz bu işe daha çok konsantre olduk. Her hastadan sonra örtülerimiz zaten değişiyordu, gene değişiyor ama yüzeyler tekrar siliniyor. Sehpalar, her hastadan sonra sandalye kolları, kapı kolları, ışık düğmeleri hepsi temizleniyor. Ayrıca Türkiye'nin dört bir yanındaki hastalarımıza video klinik olarak da hizmet verebiliyoruz. Bilgisayar üzerinden kamera aracılığıyla sizler bizi görebiliyorsunuz, bizler sizi görebiliyoruz. Burada bilgisayardaki bütün sonuçlarınıza ulaşabiliyoruz. Tıpkı yüz yüze görüşüyormuş gibi sonuçlarınızı değerlendirebiliyoruz. Poliklinik hizmetlerimiz güvenli, acil servis hizmetlerimiz güvenli, tetkikleriniz güvenli, ameliyatlar güvenli. Ameliyathane güvenliği için de gerekli tedbirlerimizi aldık. Bu konuda şimdi ameliyathane sorumlumuz Profesör Doktor Didem Dal Hoca ile görüşeceğiz. Buyurun. Profesör Doktor Didem Dal'la birlikteyiz. Sayın hocam, bu süreçte ameliyatlarla ilgili ne gibi tedbirler aldık?
Bu hassas dönemde kesinlikle sağlığınızı ihmal etmeyin. Sağlığınız için gereken tetkikler, gerek bir ameliyat, herhangi bir işlem gerekiyorsa güvenle, doktorlarınıza güvenerek, hastanelerinize güvenerek gelebilirsiniz. Çünkü onlar sizler için, sizlerin güvenliği için tüm tedbirleri alıyorlar. Aynen kendi sağlıkları ve güvenlikleri gibi sizlere de her tür hizmeti sunmaya hazırlar. Bizler de bunları yapmaya çalışıyoruz.
Benimle bu hastane turuna katıldığınız için teşekkür ederim. Live Hospital Ulus'u sizler ve hastane personelimiz için mümkün olan en güvenli hale getirdiğimizi umuyoruz. Sizler için buradayız ve hizmete hazırız. Tedavilerinize devam etmek istiyoruz. Unutmayınız, güvenliyiz ve sizi de güvenli tutmak için buradayız.
Good morning, everybody. It's great honor for me to be here and make this small presentation for you. I wish you all a good day, and we'll be together for around 1 hour. You know, in pediatric group, when we planned this ICMAS presentations, we were trying to make the conditions regarding to the cases. And with this light, actually, we planned as a pediatric surgery the same. And, you know, as a pediatrician or family practitioner or interns or medical students, you know, as a pediatric, and also we as a pediatric surgeons, we open the diaper of the baby and we see some problems. So that's why today we planned this kind of presentation to you. So here is one baby with diaper, and when we open the diaper, actually we see 3 different types of the appearance. One can be a male, a boy, or a female, a girl, or sometimes we can't define or say exactly if it is boy or girl. So we will start with the appearance, which is boy, and in these children we see we exactly look through 2 sides. One of them is inguinal-scrotal pathologies and also penile abnormalities. Here we can see. So when we look at this area and focusing on inguinal-scrotal area, we can see 3 different types of the appearance. One can be inguinal-scrotal swelling, another can be scrotal pain and redness, and or empty scrotum. The scrotum can be without any testicle or mass inside of it. So when we see inguinal-scrotal swelling, actually we consider this diagnosis. One of them is inguinal hernia, hydrocele, testicular tumor, traumatic hematocele, or scrotal edema. Here you see one case with scrotal edema. The typical appearance in this scrotal edema, it's together with the penis, not only in scrotum. Traumatic hematocele has always history about this. So actually we will focus on inguinal hernia, hydrocele, and the inguinal hernia and testicular tumor. For understanding the reality in inguinal scrotal area pathologies in children, we should know that testicular migration is important because, you know, testis is an organ normally in the abdomen during the embryonal period. And this organ make a migration and comes to the scrotum. And when during this migration, the peritoneum also goes down to the scrotal area, and we call it processus vaginalis. These processus vaginalis problems actually are always together with inguinal-scrotal pathologies in children. Inguinal hernia develops in late pregnancy when the processus vaginalis fails to close. It should be closed before the labor. So if it doesn't close, we see some pathologies, and one of them is inguinal hernia, in which this processus is completely open. And so the communication between the abdominal cavity and the inguinal canal continues. The majority of the hernias in children are indirect on the right side, and almost all of them are congenital. 10% of them are bilateral, and prevalence changes with some related conditions, and of course with the age of the child. The prevalence is higher in prematures and small for gestational age. Of course, diagnosis is in the beginning is made by the observation. So the child's family, or the doctors can see a swelling on the inguinal-scrotal area. Of course, ultrasonography is very important, and during ultrasonography, as you see here, we can detect the inguinal hernia easily and completely. Differential diagnosis is important because when we see swellings in one side or in both sides of the scrotal area, we should think, or we should consider all the reasons which makes the swelling there. And of course, hydrocele, testicular tumor, hematocele, scrotal edema, varicocele, lymphadenopathy, psoas abscess, undescended testicle, and retractile testis should be considered in the mind for differential diagnosis. Of course, this slide is really very important as the physicians for you, because you can see inguinal hernia in many conditions, but you should know that it is together with another condition sometimes. So when we diagnose inguinal hernia, we should think if there is a cystic fibrosis in this child, or any connective tissue disease like Ehlers-Danlos syndrome or Hunter-Hurler syndrome. Also, inguinal hernia is together with developmental dysplasia of the hip, chronic peritoneal dialysis cases, premature cases, especially with intraventricular hemorrhage, and ventricular peritoneal shunts with meningomyelocele, and it is sometimes 70% of the cases of the undescended testicle, they have inguinal hernia. Treatment depends on the condition, or if there is no complication of hernia in this child, we should take the child to the operation theater as soon as possible after diagnosis. We can do open surgical treatment or closed surgical treatment. If there is a complication, the main complications for hernia, as you know, are incarceration or strangulation, and sometimes evisceration. If there is an incarceration, of course, the first thing that we have to do is manual reduction. And after this reduction, we take the child to the operation theater after 72 hours. If there is strangulation, which shows that the blood vessels are also closed, we should take the child to the operation theater in emergency conditions. Hydrocele is the second headline of the swelling on scrotal area. Here it's different. This is normal appearance in which the processus vaginalis is closed, the processus vaginalis is open, and the organs inside of the abdominal cavity are coming down. But in hydrocele, this potential area around the tunica vaginalis is full with the fluid. So here the opening is not as big as hernia, it is smaller, or sometimes it's closed, but there is still a fluid accumulation here. So if there is a connection between the abdominal cavity and the scrotal area, we call it communicant hydrocele. If there isn't any connection, we call it non-communicant, and these are the primary hydrocele reasons. On the other hand, there is secondary conditions in which we can see hydrocele, like torsion, like orchioepididymitis, or tumor, testicular tumors, or after trauma. The typical appearance or physical examination finding of the hydrocele is transilluminating cystic mass. Treatment options actually depends on the type of the hydrocele. If it is communicant, we know that if the mass increases during the day or by crying, and if it decreases at night, it shows that there is a relation between inside and outside. And we know that these are, in these cases, spontaneous closure is unlikely, and the hernia can happen by the time. So in these cases, we have to make operation as soon as possible. In non-communicant cases, as there isn't so much complication or complication rates, we can wait till 1 year of age or 1.5 years of age. Maybe it resolves by itself. So we give this chance to the children. Another type of the hydrocele is called hydrocele of the cord. This is interesting because in these cases, the connection between abdominal cavity and the processus vaginalis remnant is closed, but between testis and the internal ring of the inguinal hernia, inguinal area, there is a cyst. We call it hydrocele of the cord. Actually, in girls, we also see this, but we do not call this hydrocele of the cord. This is cordon kyst for the males, and in the girls we define them as a cyst of NAC cyst. The treatment in these cases is like non-communicant hydrocele, so we can wait till 1 year of age. Testicular tumors are another reason of the testicular swelling in children, and most common solid tumor in children between 15 to 30 years old men is testicular tumor, and these tumors is around 20% of all cancers in this group. Typically, these cases has a mass, rapidly growing, and paleness. It's not transilluminated, and with the ultrasonography, we can diagnose it at a baseline. Here you see one tumor inside of the testis, and after ultrasonography, of course, for grading and everything, we continue with the other radiologic interventions. Second thing that we can see in scrotal area is scrotal redness and pain, of course, with swelling. So these three things, scrotal pain, redness, and swelling, when they are together, we call it acute scrotum, which is one of the most emergency condition in pediatric urology and pediatric surgery. The reasons of acute scrotum can be divided to the 5: testicular torsion, torsion of the appendix testis, orchitis or epididymitis, incarcerated inguinal hernia, or trauma can be the same clinical picture, which is acute scrotum. In testicular torsion, which is very, very important for us, as you will see now, because the time is very important, diagnostic time is, it is a torsion of the spermatic cord and vessels around the testicle. It is 1 in 4,000 men under 25 years of age. And interestingly, these cases have a bimodal age distribution. In neonatal period, like you see here, and in puberty, we see more commonly than the other age groups for testicular torsion. And in these cases, there is one predisposing anatomy. It's a kind of deformity, and Clapper deformity. It is a fixation anomaly, and prevalence is not very rare. It's 1 in 125 cases, and it is typically bilateral. The mobility has increased in these cases, and the testicle is placed transversely. So these two conditions makes the testicular torsion easier in this, makes the testicular torsion common in these cases. Rapid clinical diagnosis is very important in testicular torsion. Even if we are not sure about the acute scrotum reason, we should always think the testicular torsion as a first diagnosis. So we should go to radiology rapidly, and we do two things for the diagnosis. One of them is color Doppler, and another is nuclear medicine studies. In color Doppler, we see decreased here, as you see, this is normal with normal blood flow. Here, there's a decrease of the blood flow, which shows that can be a testicular torsion. Sensitivity is around 69 to 10 to 100%, and specificity is 77 to 100%. Good results. But sometimes we can have wrong positivity in these cases, especially if there's a large hydrocele or hematoma. The color Doppler is not very much trustable. And in nuclear medicine studies, we see that there is no blood flow on the testis, and this is also bigger and better sensitivity and specificity. If we diagnose testicular torsion in 6 hours, the viability of the testicle is 100%. If we diagnose it between 12 to 24 hours, viability decreases to the 70%. And after 24 hours, after 1 day, viability is 0. So this is very important to diagnose the testicular torsion as soon as possible. And time is testicle, we see. This is necrotic and late case. So when we diagnose, we could go to the operation theater immediately, and surgical detorsion should be done. If there is a deformity, we should do the fixation to the contralateral another testicle, and if the necrotic testis is existing, orchiectomy is is the modality of the surgical condition we choose. Torsion of the appendic testis is interesting because this is actually a embryonal duct, Müllerian channel duct remnant. And these remnants, like here as you see, is on the testis. And sometimes, especially after prepubertal estrogen and androgen effects, with these effects, this can be growth and becomes bigger, and the torsion can happen in these cases. This is pedunculated, like as you see here, and it is around 0.3 centimeter long. And typically, when you in the physical examination, you see a little bit bluish appearance on the scrotum. We call it blue dot. Orchitis and epididymitis are actually not surgical reasons, but it is one of the most common problem which can be taught as testicular torsion. So it is again swelling, tenderness, redness together, acute scrotum, but there is a shiny, very typical shiny appearance of the scrotum, and there is edema on it. Very importantly, the posture is in normal vertical condition. If it is together with epididymitis, like you see here, also the child can have some urinary symptoms pain in urination, like pain in urination. And the most common reason of orchitis and epidermitis is the infections, general infections, and especially the viral infections like mumps, Coxsackie virus, echovirus, or parvovirus. Of course, in Doppler ultrasonography, we can differentiate this from the torsion because here there is an increase on blood flow. You know, the decrease in blood flow shows torsion, increase shows infection. Another reason of acute scrotum is incarcerated inguinal hernia. Here there's an incarceration and the clinical picture is very dramatic. The case has a swelling and pain together. And in these cases, there is hernia story in some cases, but it doesn't have to be, especially in children, because sometimes these children comes to us with this, first with this incarceration. So we should be very careful. Here, ultrasonography is important. And in ultrasonography, this is testicle, this is herniation, and inside of the herniation, there is a bowel. Third headline of the diaper, when you open, it's empty scrotum. The reasons of empty scrotum are undescended testicle, retractile testicle, ectopic testicle, testicular agenesis, and the vanishing testis. These are the reasons of empty scrotum. Of course, the most important one is undescended testicle. The frequency of this condition change with the age. At birth, it is around 3 to 4%. In a year, it becomes 1%. And for prematures, it's around 30-40%. And if the child is under 900 grams, it's 100%. So this depends. This shows that the migration couldn't be finished during the labor, so it's continuing. Actually, in the physical exam, diagnosis starts with the families or the doctors. They know and they send these children to pediatric surgery clinics. And in the physical examination, 85% of these cases are undescended testicles, are palpable here, for instance, and in the 15% of the cases, it's non-palpable. And the most common place in the palpable ones is high scrotal area. If we find a palpable testicle, then we start to follow up these cases for 3 months periods. And around 1 year, we do open orchideopexy. If there is non-palpable one side and another one is palpable, we go for this ultrasonography. If we find the testicle in ultrasonography, we again repeat ultrasonography at the 6 months of age, and around 1 year we do open, or depending on the place of the testicle, maybe laparoscopical orchideopexy. If we do not find this this testicle in ultrasonography, it's non-palpable, and without seeing in ultrasonography at the 6 months of age, we go for laparoscopy. In this laparoscopic intervention, we first try to find the testicle, and then, if possible, we take it to its place, make orchideopexy. If there are two sides non-palpable testicles, then if we find it in ultrasonography, like one side, we go to orchideopexy in 1 year. But if we cannot find the testicles in ultrasonography, we make androgen stimulation test if there is any testicular tissue inside or not. So if this test is negative, we call it vanishing testicle, or testicular agenesis in both sides. No response to androgen, no testosterone response to androgen shows that there is no testicle. If test is positive, then we go for laparoscopical studies and laparoscopical intervention for diagnosis and treatment. Hormonal therapy. In some countries, unfortunately, we see that the people goes for hormonal therapy for undescended testicle. For a real undescended testicle, we do not use any hormone therapy. The treatment in testicle is only surgical. In the last 10 or 20 years, we also started to see some cases, we call it acute undescended testicle. This is important headline and knee, because ascending testis was not a condition actually we deal or we expect. But now we see that especially in the retractile testicles, sometimes the testicle go to up after, first it's in the scrotal area, then the ascension can be seen. So it's more common around 8 years, and especially retractile testicles should be followed up closely. And also another acquired undescended testicle reason is iatrogenic reasons. These are undescended testes after some inguinal surgery operations. You know, we have to treat these cases because the temperature is important. So we know that inside of the body it is around 37, in inguinal region it's around 35, and scrotal region it's around 33. So this temperature effect makes some problems like infertility, like malignancy, like malignancy. So in addition to these effects of temperature, also these cases, these children with undescended testicle have increased risk of torsion, and the cosmetic appearance is important. Also social trauma, it's a kind of social trauma, empty scrotum. So these cases should be operated. And ultrasonography in undescended testicle is really controversial because sometimes the people tries to define the location of the testicle with ultrasonography. This is completely wrong. Okay, we use ultrasonography in these cases for finding the testicle or determination of the condition of the testicle and the sizes of the testicle if there is any hazardous problem before the operation. Retractile testis is also called shy testis or yo-yo testis. This testicle actually had gone to scrotum, to its normal place, but with the cremasteric reflex, due to cremasteric reflex retractions, it goes up to the inguinal channel. So in the examination, as you see here, the testis is brought to the base of the scrotum and without difficulty, and we place it there and wait for 30 seconds after we released. And if this testicle is staying in its place, so this is a retractile testis, this is not an undescended testicle. And this can cause, again, I repeat, ascending testicle by the time. And the appearance of the scrotum is a good clue because if the appearance is normal, it is retractile testicle. If there is a hypoplastic appearance of the scrotum, it is undescended testicle. The treatment, actually, there's a debate on it. It's a controversial, and we know, and also the guidelines of European urology guidelines, European Association of Urology, they say that no treatment required. It should be followed closely until puberty. So follow-up. Ectopic testicle is another reason of empty scrotum. The placement of the testis is, if it is not on the migration road way or path, we call it ectopia. So the testicle goes not to its normal place, it goes to different places, and most commonly it's perineal, and there is no need to wait for these cases because it never comes to scrotum. So when we see these cases, we should do the operation around 6 months of age to put the testicle to its place. Okay, let's go back to diaper. First, we had focused on the inguinoscrotal area. Now we will focus on the penis. So penile abnormalities. We can divide all penile abnormalities in children to two main topics. One of them is congenital, another is acquired. Now let's see these congenital and acquired ones. Phimosis, one of the most common diagnoses we make during infancy. It is defined as the opening of the foreskin is narrow enough and it causes difficulty in urination and it is inability to retract the foreskin. So when you look at these cases, there is a glans head of the penis and loose retractable foreskin. So this is normal. In phimosis, tight, unretractable foreskin occurs. Here you see this is also looks like small opening, but this is normal. But in this case, as you see, it is tight and closed more tightly, and you can't retract it back. This is phimosis. Of course, the appearance of the foreskin and ballooning during the urination, again, ballonid attacks, and if there's a urinary tract infection, we should recommend treatment. There are two treatment options. One of them is medical treatment. We use topical steroid for 2 to 6 weeks, and the success rate is not low. Surgical treatment, circumcision is one of the surgical treatment option, or if you do not want to circumcise your child, then you can make pre-pisioplasty to make opening more bigger and relax. Paraphimosis is important condition because it is another emergency condition in pediatric urology. Here, the foreskin cannot be brought back to the glans penis, and so the appearance is like that, and it's very dangerous because this foreskin can result the decrease in blood flow of the glans, and it can even result necrosis. It usually creates by the families, and urgent intervention is required and important. Sometimes we can do it manually, sometimes we go for operation to release the blood flow of the glans. Micropenis is another headline of the penile abnormalities. Actually, the definition of micropenis is not easy. Here you see the same case. This is the without erection, this is only with pulling back, and this is erection. So it's not easy to say for one penis if it is micro or not. Actually, there are some rules, of course. The length between the symphysis pubis and the tip of the glans should be examined, and then we should look at the penile size standard derivations, and if it's lower than 2.5 standard deviation, we call it micropenis. Or in all age groups, this length should be more than 19 millimeters. So here you see a real micropenis. This is buried penis. We'll talk about this, not a real one, but after we find micropenis, of course, these children should go to the pediatric endocrinology. Buried penis is, we call it concealed or buried penis, can be sometimes congenital. In congenital cases, the ligaments of the penis, which in dorsally and ventrally, the junctions did not exist. If these junctions are not in their place, then the penis goes inside. We call it buried penis. Sometimes after circumcision or after penile surgeries, postoperatively we can see buried penis. And some skin disease like balanitis, xerotica obliterans can result with buried penis also. Here is the buried penis. As you see, there is no penile skin and the penis is inside. Wet penis is there is a kind of web on the ventral side. So as you see here, this is very typical appearance, and also this is before and after surgery. The reason that we operate these cases are it can cause curvature during erection. It can pull the penis down, and this can make painful intercourse. And of course, the cosmetic appearance is important because this penis stays like that. Penile torsion and curvature is another penile abnormality that we see, and degree here is very important in both in torsion or curvatures. The curvature should be measured at the erection, during the erection, and if it is above 30 degrees, it should be corrected because the child or the male can face with some problems. Isolated curvature, ventral curvature, should be also corrected because this can make again the same problems like painful intercourse and the cosmetic appearance. Hypospadias may be one of the most important headlines of this speech today. It is the most common external genital anomaly which requires correction. It's around 46 cases in 1,000 men. It is a congenital abnormality in which there is an insufficient development of anterior urethra. So the urethral meatus is not on its place, it's down on the ventral side, and the location is not here, as you see here or here. So actually, the problem is not only that the external urethral is meatus, ventral, but all the tissues that make up the penile urethra and the prepucium are hypoplastic. We divide the hypospadias into two. We put a line just in the middle of the penis, and if the urethral meatus is more distal to this line, we call it distal hypospadias. If it's more proximal, we call it proximal hypospadias. And the distal type is the most common, and the most common one is subcoronal type. And in most cases, it is together with ventral curvature, we also call it chordee. And especially in proximal hypospadias cases, another congenital urinary abnormalities can be together. So in these cases, we should do ultrasonography. Here you see different types of hypospadias that we operated here. And this is the distal one. This is proximal penile, base of penile. This is one intersex case. And this is between perineal. It is under scrotum. here it's between scrotum, and there is also bifid scrotum here and bifid scrotums here. Treatment is surgical, and we should make the adequate, good urethra, and depending on the severity of the hypospadias, we can do 1 or 2 stage operation. This is 2-stage operation before operation. This is after operation. You can see that the case is peeing very good. Epispadias is different because in these cases, again, the urethral meatus is not on the tip of the glans, but now the urination is on the dorsal side of the penis, and it is very rare and usually together with bladder extrophy. Here are the single cases without extrophy. They pee from the dorsal side. And depending on the level, because this is important, these cases may remain incontinent through their whole lives. And of course, like proximal hypospadias, in these cases, we should also do ultrasonography studies. Here are one of case with epispadias. It is in the beginning and during the operation, and this is the end of the operation. Bladder extrophy, these are rare abnormalities. For penile abnormalities, actually it is defined as the closure defect of the infraumbilical abdominal wall. Here you see bladder, there's a bifid penis, bifid scrotum. It is more common in males, and it's one in, luckily, fortunately, one in 30,000 to 40,000. In these cases, there are 4 types of the defects together with the same case: anorectal defects, musculoskeletal defects, genital defects, and urinary defects. Here is the one case before operation, and we also do osteotomies with orthopedics, pediatric orthopedics, and this is the end of the operation for extrophy. Cloacal extrophy is actually very rare, but it's more complicated than bladder extrophy. In these cases, as you see, in addition to all extrophic bladder conditions, there is an omphalocele together and also anal atresia. We can also see some very rare abnormalities when we open the diaper, like cyanomelia. It is the agenesis of external genitalia and lower limbs. Aphalia, there is no penis. Diphalia, there are 2 penises or some transpositions of the scrotum or penis we can see. The last headline is actually when we open the case, we are not sure if it is a male or female. So we call it intersex or sexual development defects. We know that for human sexual differentiation, the main starting point is chromosomal sex. Our chromosomes makes the gonads, our gonads, and the gonadal sex defines the internal and external genital sex. So for definition of the sex, there is a gene, we call it SRY, in the short arm of the Y chromosome. If this gene is present, then the testis happens. But if it is absent, then in 2X chromosomes, the ovary happens. So the potential gonad can be normally the process goes to the female. So if there is this gene, then the process changes to the male and the testis occurs. For us, important clinical condition is, when we open diaper, what we see, and when we see some things, we will think that it is ambiguous intersex case. For the males, for females, actually when you first female, there are some clues which shows that in newborn and infants, this can be an intersex patient, like clitoromegaly, like here, some hyperpigmentation, labial fusion, or inguinal mass, bilateral inguinal mass, like here. If the cases looks like boy, then also if there is micropenis with empty scrotum, we should think that maybe this is an empty scrotum. Or if there is distal hypospadias with bilateral undescended testicle, or proximal hypospadias with undescended testicle, one or two-sided. So this is this can be taught as intersex in these cases. If there isn't any suspicion during infancy and newborns, sometimes at puberty we can face with the intersex cases. If there's a delay in the puberty or amenorrhea, like a Turner syndrome here, or if there is a virilization at puberty, which was looking like female, or if there's an inguinal hernia with mass, with the girl appearance children, we should think if there's an ambiguous genitalia or not. Or for a boy who was grown as a boy, if there's a micropenis at puberty or hematuria or infertility or gynecomastia, in these cases, we should think if there is an intersex or not. The conditions which makes intersex, which causes intersex, are actually divided into 5. The most common one, female pseudohermaphroditism. Female pseudohermaphroditism means that these children are genetically female, 46XX, but the appearance is not like, the phenotype is not a girl. It's ambiguous or like boy. The most common one is congenital adrenal hyperplasia, and the most common in this group is 25-hydroxylase deficiency. In male pseudohermaphroditism, they are genetically male, but the appearance is different. In true hermaphroditism, both testicle and ovary is in the same body with the same in the same person. So if one has testicle and ovary together, we call it true hermaphroditism. In gonadal dysgenesis, as I had shown you in the beginning of intersex, the gonads are important determination factors for the genitalia. There's a dysgenesis, and of course, in some chromosomal abnormalities like Klinefelter, Turner syndromes, we can face with the intersex cases. Here, the most important thing for you in practice, in clinical practice, when you face with ambiguous genitalia, you should look to the gonads. If there is a gonads bilaterally palpation, this is more commonly male pseudohermaphroditism. If there is gonad in one side and if it is absent in the another side, it is most commonly true hermaphroditism or mixed gonadal dysgenesis. And if you don't palpate any gonads, it's a female pseudohermaphroditism. The operation that we do in these cases is feminizing genitoplasty. Here is the beginning, and this is the end of the case after the operation. We do 2 things, reduction clitoroplasty and the posterior flap vaginoplasty. A new clitoris here and the vagina has been created here. I thank you very much to all of you for your interest. Here it is my email and Instagram. So whatever you want to ask, whatever you want to make comment about this presentation or about pediatric surgical, other pediatric surgery, surgical disease, you are welcome. On the other hand, I would like to thank so much to Istinye University, Liv Hospital, and especially our international group, which makes International Contemporary Medical Academy of Science. Thank you very much. Have a good day. Bye-bye.
Good day and welcome. My name is Katerina Tikhanova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of the treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника ЛИВ, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники ЛИВ желает вам благополучных дней.
Live Hospital.
Good morning. Today, I will tell you about preoperative management of newborns with critical congenital heart disease. Congenital heart defects are the most common causes for acute cardiac failure in neonates. Critical congenital heart disease is defined by an associated systemic low cardiac output requiring surgery or catheter-based intervention in the first year of life. The prevalence of congenital heart disease is about 1% of all live births and is therefore one of the most common congenital malformations. critical congenital heart disease are approximately 15 to 25% of newborns with congenital heart disease. Despite considerable progress in the cardiosurgical, interventional, and intensive care treatment of newborns, it remains a leading cause of infant morbidity and mortality, with a mortality rate up to 25% in the first year of life. So the importance of the subject is early diagnosis and initiation of adequate treatment are of utmost importance. The shunt lesions, representing the largest proportion of the congenital heart disease, remain usually stable during the neonatal period. Symptoms of congestive heart failure do not manifest themselves until the pulmonary vascular resistance decreases within the first 3 months. Critical congenital heart disease, on the other hand, leads already to serious but unspecific symptoms in the newborn period. The lesion determines the time of the onset of symptoms, which can occur immediately after birth or within the first week of life. The distribution of critical congenital heart disease differs from the distribution of congenital heart disease in general. Left heart obstructions had the largest share with 30 to 40%, followed by complete transposition of the great arteries. It was approximately 30%, and right heart obstructions, which accounts 20 or 30% of all cases. When we talk about the prenatal diagnosis, the detection rate of critical heart defects has improved over the last decades, but is still inadequate despite improved prenatal diagnostics and postnatal clinical examinations. The sensitivity of prenatal diagnostics for critical heart defects is reported to be up to a maximum 60 or 80% in different studies. The postnatal diagnosis, the sensitivity of the clinical examination in the first days of life for detection of the critical congenital heart disease is less than 60%. This may be due to a possible symptom-free interval, which we call as diagnostic gap, due to the delayed change from the fetal to neonatal circulatory physiology. We use pulse oximetry screening for detection of critical congenital heart diseases. The pulse oximetry screening is a proposed method by which this postnatal diagnostic gap should be reduced. However, pulse oximetry screening does not replace a careful examination. Now I want to talk about the fetal cardiovascular physiology to better us understanding the pathology of the congenital heart diseases. The fetal cardiovascular physiology with a right to left shunting, foramen ovale and ductus arteriosus, with a high pulmonary resistance and low systemic vascular resistance, allows to a large extent a normal fetal development for the majority of the cardiovascular malformations, as long as the gas exchange is guaranteed by the placenta. We see here the diagram of the circulation in the normal fetus. As you can see, the placental well-oxygenated venous blood past the ductus venosus is preferentially directed through the foramen ovale to the left atrium. From the pulmonary trunk, a large proportion passes through the ductus arteriosus to the descending aorta. Now note the higher oxygen saturation in ascending compared with the descending aortic blood. The low saturation of pulmonary arterial blood. Umbilical clamp placement terminates the placental circulation, including the maternal extracorporeal oxygenation. Now the baby is alone, and the transition from the fetal parallel to the adult serial circulation is forced by the quality of postnatal pulmonary gas mixture. Umbilical cut increases systemic resistance, and related to lung expansion, it decreases the pulmonary resistance over days to weeks, achieving low resistance of almost adult level after 6 weeks to 3 months. This phase of postnatal circulatory transition is very variable and influenced by functional and anatomical considerations. Often ductus arteriosus and foramen ovale can lead to inconspicuous clinical findings in newborns with critical congenital heart disease. This period is therefore also referred to as diagnostic gap. Transition to a serial circulatory physiology might lead to a life-threatening condition in the presence of critical heart defects. There is factors responsible for postnatal duct closure. Duct closure is very important in critical congenital heart disease when the termination of the placenta circulation and with it the main source of prostaglandin production, the postnatal duct closure started to switch over from the intrauterine to extramaternal environments with increase of pH and partial oxygen saturation, and the rise of the pulmonary prostaglandin dehydrogenase production causes the postnatal duct closure. The anatomy of foramen ovale enables a right to left, but not a left to right shunt. So the foramen ovale closure is related to a rise of the left ventricular afterload and increase of the left atrial pressure, usually to a level of 3 to 5 millimeters mercury higher than the right atrial pressure. The contraction of the ductus arteriosus is finally followed by the obliteration. In duct-dependent congenital heart disease, ductus arteriosus closure leads to a life-threatening situation due to a compromised systemic blood flow. Restoring the parallel circulation with an arterial and or atrial communication is therefore mandatory for most critical congenital heart disease. We use medical reopening of a closed or narrowed ductus arteriosus by infusion of prostaglandin E1 is possible in any pediatric institution. In general, the lowest effective dosage, which induces as few side effects as possible, should be sought. An almost closed duct responds in most cases to continuous infused prostaglandin E1 in a dosage of 20 nanograms per kilograms per minute. It needs rarely 50 nanograms per kilograms per minute. High dosages of prostaglandin E1 have to be rapidly reduced after effective reopening. In particular, in congenital heart diseases with ductus-dependent systemic blood flow, a prophylactic dosage of 5 to 10 nanograms per kilograms per minute remains usually effective with a low incidence of side effects if we know antenatally there is a critical congenital heart disease in neonates. Specialized pediatric heart centers are able to perform duct stenting as an alternative to less effective prostaglandin E1 infusion or in non-responders babies. For example, shock patients with metabolic acidosis frequently needs duct stenting rather than prostaglandin E1 infusion. Further measure requiring also a pediatric cardiologist is the manipulation of the atrial septum. Whether enlargement of an ineffective or restrictive foramen ovale or by creation of a new atrial communication. The technical arsenal ranges from a Rashkent maneuver to static ballooning or stent placement, and Rashkent procedures can be performed by ultrasound guidance on the pediatric or neonatal intensive care unit. Extreme restrictive or a complete closed atrial septum require an advanced transcatheter intervention in specialized centers with a high level of expertise. The parallel pulmonary and systemic circulation is a sensitive construct, massively influenced by the diameter of the arterial communication and the ratio of pulmonary and systemic resistance. Clinical impairment might be the result of low cardiac output based on pulmonary hypercirculation. This is especially true for clinical congenital heart diseases with left heart obstruction, when the systemic blood flow depends on a high pulmonary resistance and thus a postnatal right to left shunt on the ductal level. Diminished organ perfusion is clinically observed by tachypnea, high arterial oxygen saturation combined with a pale skin and a narrow systemic blood pressure amplitude. Considering these pathophysiological sequences underlines the danger of using mean arterial pressure instead systolic and diastolic values for therapy monitoring and guiding in this particular high-risk patients. When there is an imbalance of the parallel circulation, the causative factors are the inadequate administration of oxygen, application of excessive prostaglandin dosage, unnecessary mechanic ventilation, hyperventilation, inadequate bicarbonate administration. These are the factors that cause imbalance of the parallel circulation. Indiscriminate use of catecholamines with its systemic vasopressor effects and associated tachycardia, resulting in increased oxygen consumption and decreased diastolic feeding time, can also lead to an imbalance of the parallel circulation. Considering a normal lung function, measurement of a systemic arterial and venous oxygen saturations allows estimating the ratio of pulmonary and systemic blood flow. This ratio is calculated according to the fixed formula. In most clinical settings, the primary axis for saturation measurements is restricted to arterial or transcutaneous oxygen saturation values. Considering formula, a post-ductal target saturation between 75 to 85%, it means the mild clinical cyanosis, can in most cases be assumed to be equivalent to a balanced pulmonary and systemic pressures. Now I want to talk about a basic grouping of the congenital heart diseases. The congenital heart diseases with a high risk for critical hemodynamics are divided into following basic groups. The first group is with duct-dependent systemic blood flow and pulmonary blood flow groups, duct-dependent groups. The second group is the non-mixture group, which is the complete transposition of the great arteries, and the complex type are the third group. The congenital heart disease with duct-dependent systemic blood flow is mainly the critical aortic stenosis, critical aortic coarctation, interrupted aortic arch, and hypoplastic left heart syndrome and hypoplastic left heart complex. The duct-dependent pulmonary blood flow constitutes with critical pulmonary stenosis, pulmonary atresia with intact septum, pronounced types of Fowler's tetralogy, and pulmonary atresia with VSD, ventricular septal defect, atresia of the tricuspid valve with pulmonary stenosis or atresia, Epstein's anomaly or tricuspid valve dysplasia with pseudo or anatomical atresia of the pulmonary valve. The complete transposition of the great artery is classified as non-mixture or inadequate shunting at atrial, ventricular, or duct level. The others, the complex one, are total anomalies where pulmonary venous return with obstructed pulmonary vein flow, common arterial trunk with significant truncal valve irritation, and univentricular heart with imbalance of systemic or pulmonary circulation. These are the rare ones. Now I want to talk about the first case, that 39 weeks old female infant with 2.9 kilograms. There is an antenatal diagnosis with hypoplastic left heart syndrome, no need of resuscitation in the delivery room, and we immediately started prostaglandin E1 infusion at postnatal first minutes with 10 nanograms per kilograms per minute. And we stabilized the baby with a saturation of 85% in room air. Blood gas analysis was normal, compensated blood gas, no X-ray anomaly, and the postnatal fourth date, we make the person, applied person to room Norwood for Norwood stage 1 procedure. Post-operatively, she needs 3 days ECMO support and 40 days invasive mechanical ventilation and 22-day post-operatively discharge from the intensive care unit. Now, this is our first case, but there is a same case in case 2 with a small difference. 38 weeks female infant with nearly 3 kilograms, no antenatal diagnosis. This is the important point. No need for resuscitation in delivery room, same in the first case, and postnatal third day at home. He went home with mother, and the parents noticed that their peroral cyanosis and applied to external centers, the emergency department. there is 65% oxygen saturation and baby in ill situation. Rapidly intubated and hospitalized to neonatal intensive care unit, the blood gas reveals decompensated metabolic acidosis. And after intubation and 100% oxygen, the saturation goes 70, only 5% increase reached. In echocardiography, they found hypoplastic left heart syndrome with a PDA nearly obstructed. 50 nanograms per kilograms per minute, the high dose prostaglandin E1 infusion started, transferred to our centers immediately for operation and management, and Norwood stage 1 procedure at 5th postnatal day applied, and 14 days ECMO support postoperatively, but the patient exudates because of the left ventricular failure after 14th day. This is the importance of the antenatal diagnosis. When we talk about the congenital heart disease with ductus-dependent systemic blood flow, the left heart obstruction, the critical obstructions of the left heart, including the ascending aorta and the aortic arch, result in a ductus-dependent systemic perfusion. The critical means impaired hemodynamic conditions as a consequence of the cardiac obstruction, leading to systemic low cardiac output. An open arterial duct is the most important component avoiding low cardiac output. All left ventricular structures might be affected as single or multiple lesions ranging from the critical inflow or outflow obstructions. It can be mitral valve stenosis, aortic valve stenosis, aortic coarctation, interruption of the aortic arch, hypoplastic left heart syndrome, or hypoplastic left heart as shown complex or borderline left ventricle. However, in spite of left heart functional failure, if we achieve the ductus-dependent systemic flow, it's expected for systemic blood flow and the patient survive. So the first procedure is always to open the duct. Depending on the morphological or functional severity, the right ventricle has to take over the workload, supplying the pulmonary and systemic circulation completely or partially with an open duct. In the absence of antegrade perfusion, it can be in highly impaired left ventricular function, aortic atresia, or hypoplastic left heart syndrome. Coronary and cerebral perfusion depends on retrograde perfusion into the ascending aorta with the arterial duct. In general, the hemodynamics of such a physiology are very fragile. Already, a slight obstructions of the ductus arteriosus, all conditions decreases the pulmonary resistance or the persistence of a relevant preductal aortic coarctation are immediately associated with life-threatening brain or heart ischemia. As obstructions of the left heart usually lead to a forward failure of the left ventricle, at least at the beginning, the pressure in the left atrium is increased and accordingly, a left to right shunt is present with atrial communication. If a significant atrial left to right shunt is present, oxygen saturation is relatively high in the pulmonary artery and the consecutive in the descending aorta. Cyanosis is not necessarily clinically detected. If a shunt is missing or if the atrial communication is restrictive, blood will dam back into the lungs and can lead to passive pulmonary edema. Restriction at the atrial level can therefore lead to hypoxemia with cardiovascular shock immediately after birth. Foramen ovale restriction or closure during fetal life might be associated with untreatable lymphangiectasia. Even an early fetal intervention does not often solve this life-threatening condition. What we solve with symptoms in these patients, the symptoms are related to the degree of lesion of the specific congenital heart disease. The main symptoms range from signs of acute cardiac failure up to the complete picture of a cardiogenic shock. Tachypnea is the early and therefore leading symptom. The cyanotic patients with duct-dependent systemic blood flow are usually stable because of a sufficient systemic perfusion. Patients are referred due to acute cardiogenic shock or any other degree of cardiovascular failure. Classical symptoms of chronic heart failure with feeding and weight gain problems are rare and only associated with some acquired cardiovascular conditions of the newborn as cardiomyopathy, myocarditis, ischemic heart failure, or initially less relevant congenital heart disease. Newborns with critical aortic valve stenosis are mostly symptomatic within the first week of life. A critical aortic coarctation mostly within the first 4 weeks, with a typical history of 3-week-old baby referred Friday afternoon after failure of a sepsis therapy. Considering the unspecific symptoms of congestive heart failure, sepsis or even fulminant sepsis is the differential diagnosis of choice, but therefore also the initially most erroneous diagnosis. Mostly, these newborn babies first treated for sepsis, then when it doesn't resolve, so they made the echocardiography and found the left heart obstruction lesion. In a newborn whose condition worsens clinically in the first days of life, the differential diagnosis of a critical heart defect must always be considered in addition to the suspected diagnosis of sepsis. This means that in case of doubt, a therapy with prostaglandin E1 in a low dosage can always be initiated. What we do in treatment, the first line treatment is the continuous infusion of a prostaglandin E1 in low dosage of 5 to 10 nanograms per kilograms per minute is never wrong. Treatment should immediately be started in any newborn whose condition worsens clinically in the first days of life. In particular, if the cardiovascular system cannot be immediately analyzed by the echocardiography. If you do echocardiography and there is nothing, you shouldn't start with prostaglandin E1. But if you don't do echocardiography, please start prostaglandin E1 with a low dosage. This recommendation is also true when sepsis is suspected or even confirmed by laboratory data. The basic therapeutic goals are the stabilization of the patients with restoration of the fetal parallel circulatory physiology, as well as the optimizing of the pulmonary and systemic resistance. The key points in the treatment of suspected or confirmed congenital heart disease with duct-dependent systemic blood flow. First, the reopening of the arterial duct is our first target. Initially, the high prostaglandin E1 dosage and then rapid reduction, keeping ductus arteriosus patent if we know this is the critical congenital heart disease. The prophylactic dosage of 5 to 10 nanograms per kilograms per minute started at first minutes of life. Reduction of diastolic left to right shunt across a non-obstructive right-left shunt in ductus arteriosus. The avoidance of inadequate measures resulting in the reductions of the pulmonary resistance. If you decrease the pulmonary resistance, all blood goes to pulmonary flow and the systemic blood flow become decreased and the patient goes to severe metabolic acidosis and cardiogenic shock. Reduction of systemic resistance without jeopardizing adequate perfusion pressures is important. We want the blood goes to systemic circulation, so we must drop the systemic pressure, but it is important for adequate perfusion pressures. Rapid transfer of the patient to a pediatric cardiac center is the heart of this point. Prostaglandin E1 treatment, and considering the pivotal role of prostaglandin E1 treatment in neonatal critical congenital heart disease, the lowest effective dosage is mandatory when used in any patients with ductus arteriosus dependent systemic blood flow. High dosages of prostaglandin E1 can easily compromise the hemodynamics by its side effects. What is its side effects is firstly, decrease in pulmonary resistance, apnea with the need of oxygen or intubation and mechanical ventilation, fever and tachycardia with associated high oxygen consumption of the myocardium and body, as well as low diastolic filling time. These all the side effects, and we don't want these side effects for these patients. It's very critical. Non-obstructed right to left shunting ductus arteriosus can be kept open with a prostaglandin dosage of 5 to 10 nanograms per kilograms per minute. In premature babies, the lower doses are needed. Even with a dosage of 1 to 2 nanograms per kilograms per minute is enough. Stenting of the duct has to be considered whenever the higher prostaglandin doses are initially necessary or the catecholamines beyond the use of inodilators as mirinon are required. In general, the administration of oxygen should be avoided or only be administered with the objective on an arterial oxygen saturations of around 80%, targeting the pulmonary and systemic circulation goes to 1. We want the stable parallel circulation. Treatment of a metabolic acidosis should be sought by improving systemic blood flow because the acidosis is usually systemic flow dependent. Related to an obstructed duct or pulmonary runoff, meaning pulmonary hyperperfusion at the expense of systemic perfusion, a vicious circle with decrease of pulmonary resistance and increase of systemic resistance must be prevented. The systemic blood flow depends on a low systemic resistance, which is not synonymous with blood pressure, but adequate systolic and diastolic blood pressures is important. A critical organ perfusion pressure, which means the diastolic pressure minus central venous pressure over 20 millimeters per mercury should not be undercut. In any critical care patient, the volume depletion must always be ruled out. Also, in conditions with impaired ventricular function and pulmonary edema, in this case, however, volume, if missing, small or collapsing inferior caval vein or low central venous pressure must be administered cautiously. In cardiovascular compromised univentricular hearts, hemoglobin level should be between 12 to 14 grams per deciliter. In case of hemoglobin below 11 grams per deciliter, blood transfusion should preferably be considered as volume-diagnostic. Pulmonary edema in hypoplastic left heart syndrome, excluding a pulmonary hyperperfusion, is often caused by a pulmonary venous or arterial congestion. In contrast, systemic venous congestion is usually related to ischemic myocardial failure or valvular, it means tricuspid dysfunction. What we do, underlying causes should be immediately investigated. Myocardial dysfunction should be treated preferentially by inodilators. The phosphodiesterase inhibitors, I mean mirinon, are particularly suitable for this purpose. They have a very favorable mode of action by supporting myocardial function and simultaneously reducing afterload and should therefore be considered at an early stage. When we use catecholamines, it should be with caution because the side effects, which are elevated heart rate, reduced diastolic filling time, increased myocardial oxygen consumption, and negative influence of the pulmonary to the systemic resistance ratio should always weigh against the desired effects. Nowadays, the transcatheter and or cardiosurgical procedures are not only used for definitive or palliative repair, but also for effective high urgency measures. Therefore, the newborn should be immediately transferred to a full equipped pediatric heart center. Now I want to go to this third case. It's 38 gestational weeks male baby, 2.8 kilograms, with an antenatal diagnosis with great arteries transposition, a simple type. No need for resuscitation in delivery room. It's transferred to our neonatal intensive care unit for preoperative management, and his saturation was 60 to 70% with room air. In blood gas analysis, it is slightly decompensated metabolic and respiratory acidosis. The routine prostaglandin E1 infusion started with 40 nanograms per kilograms per minute. We start high dose, then we want to reduce the dose. At postnatal first hour, we make the echocardiography and the simple transposition of great artery is founded with a PDA diameter of 3.8 millimeters and the secundum ACD ASD with 4 millimeters with left to right shunt. And we accept that it's acceptable ESD. So we start to follow up the baby. Then at postnatal 6 hours, the baby suddenly desaturated and saturation goes to 40%. And when we took the blood gas analysis, we found that there is a decompensated metabolic acidosis with a lactate levels of 6. The patient rapidly intubated and ventilated with SIMV mode, the invasive mode, but no response in saturation with 100% oxygen. The patient was immediately scheduled for balloon septostomy. The balloon septostomy was successfully applied to the patient at the bedside. The EST opening was measured as 7.5 millimeters after the procedure, and the patient's oxygen saturations increased to 85 to 90%. The prostaglandin E1 dose was gradually reduced and the patient was extubated. Arterial switch operation was successfully performed on the postnatal 15th day without any problem, and he was discharged at 24th day of life. Now I want to talk about the congenital heart disease with duct-dependent pulmonary blood flow, right heart obstructions, and the transposition of the large vessels. The cyanosis is the main and common symptom of transposition of the great arteries and heart defects with duct-dependent pulmonary blood flow. The transposition is defined by atrial ventricular concordance and ventricular arterial discordance, and therefore consists of two parallel but separate circuits. An efficient atrial defect is the most important communication, avoiding cyanosis with consecutive life-threatening hypoxic cardiovascular dysfunction. This is especially true in simple transpositions. What I mean in simple in this context is without further malformations, which is the 75% of the case. An open ductus arteriosus alone is not able to route both sufficiently deoxygenated blood to the pulmonary tract and at the same time prevent life-threatening hypoxemia in the systemic circulation. The systemic circulation is enriched with oxygen with a left to right shunt at the atrial level. An open duct increases the pulmonary blood flow, keeps the subpulmonary left ventricle longer under high pressure level, and contributes to the left to right shunt by contributing higher volumes with the pulmonary veins if there is a sufficient atrial communication. Accordingly, a persistent foramen ovale or a very restrictive atrial septal defect leads to a pronounced cyanosis as well as to tachycardia or dyspnea up to the pulmonary edema. Consecutive tachypnea and stress hormone-related tachycardia aggravates the mismatch of oxygen delivery and oxygen consumption, leading to a vicious circle. In congenital heart disease with ductus-dependent pulmonary blood flow, the morphological obstructions of the right ventricle inflow or subpulmonary outflow tract have obligatory intracardiac communications. And in most cases, an arterial pulmonary vascular communication in form of an open duct or a major aortopulmonary collaterals, which means MAP case. Some rare anatomical constellations do not need any surgical or catheter-based interventions during the neonatal period, such as the types of the tricuspid atresia, type 1B or 2B, or pulmonary atresia with ventricular septal defect or with MAP case associated balanced pulmonary to systemic blood flow. In critical pulmonary stenosis or pulmonary atresia with an intact septum, the entire cardiac output has to be directed into the subaortic ventricle with an intraatrial communication to the left atrium. In these cases, a restrictive atrial communication is rare. If it is present, the patient presents signs of a systemic venous congestion, including hepatosplenomegaly. If the arterial duct is the only source for the pulmonary perfusion, the central stenosis increase with increasing occlusion of the duct, leading to death due to hypoxemia without intervention. What we see in these patients, like symptoms, cyanosis is the leading symptom of the transposition of great arteries and right heart obstructions with duct-dependent pulmonary flow. Usually, this cyanotic newborn has compensated hemodynamics with a sufficient oxygen delivery. Therefore, the cyanotic newborn is vivid and has almost no clinical impairment. Despite an appearing vivid newborn, but because of the apparent cyanosis, the breathing support, oxygen administration, and unnecessary intubation and mechanical ventilation are often performed as first measures. The diagnosis of a cyanotic cardiac heart disease is frequently made after and because these measures do not result in significant improvement of the saturation. Cyanosis becomes critical when arterial oxygen saturation decreases continuously on less than 60% with a partial oxygen saturation with below 25 millimeters mercury, or at the latest when the metabolic acidosis becomes obvious, as our case. Even today, the following guiding principle is still valid. The cause of a cyanotic but vital newborn is a heart defect until the opposite is proven. The initial therapy has to be based on an assumed better or an established diagnosis. First, therapeutic steps should be accompanied by echocardiography as soon as possible. The basic therapeutic goal is to keep the cyanosis at a level which does not threaten the child and ensures normal somatic and neurological development. Usually, the systemic cardiac output increments with the increase of cyanosis until the anaerobic threshold is reached. Therefore, there is rarely a hypoxemia-related cerebral damage. In case of a transposition, simple transposition, balloon atrial septicectomy, which we know Rashkin procedure, is still the most effective emergency measure apart from the start of a prostaglandin E1 infusion. We start prostaglandin E1 infusion, and also we must make the balloon atrial septicectomy. A newborn with transposition should be delivered to a pediatric heart center if possible. In case of a postnatal diagnosis, transfer to pediatric heart center should be immediately prepared. If a Rashkin procedure is feasible, it can be performed on any pediatric or neonatal intensive care unit, even by umbilical venous access and also by using a diagnostic balloon catheter instead of an atrial septicectomy catheter as a transient measure. Without echocardiographic availability as an immediate diagnostic tool, continuous prostaglandin E1 infusion in a low dosage of 5 to 10 up to 20 nanograms per kilograms per minute can be applied in any cyanotic newborn without additional risk, with the chance for immediate improvement in case of ductus-dependent cardiovascular function. The therapeutic measures have to be considered in case of transposition. In summary, the reopening or keeping the arteriosus duct open by prostaglandin E1 infusion, balloon atrial septicectomy with restrictive atrial communication, rarely catecholamines, for example, norepinephrine, can become necessary in combination with high-dose prostaglandin to increase systemic afterload and to decrease the pulmonary resistance and therefore improving the pulmonary perfusion. It should be considered that the use of catecholamines is accompanied by an increased oxygen consumption, also heart rate, and can negate the benefit of the saturation improvement and even lead to metabolic acidosis. However, newborns with ductus-dependent pulmonary blood flow tolerate the application of higher doses of prostaglandin, oxygen, and mechanical ventilation quite better than the patients with ductus-dependent systemic blood flow. Prophylactic measures as mechanical ventilation, inadequate oxygen administration, high doses of prostaglandin should be avoided. A lack of volume must always be ruled out since intravascular volume depression increases cyanosis. It's the rare exception is the presence of a pulmonary edema, and diuretics are therefore rarely indicated. Depending on the severity of cyanosis, volume should be generously administered in a dose of 10 to 30 milliliters per kilograms as a challenge dose, However, a well-prepared rapid transfer of the patient to a pediatric cardiac center is the most important measure. If a prostaglandin refractory duct stenosis is present, a stent implantation in the arterial duct or aortopulmonary shunt surgery are therapeutic emergency options. Now, our last case, the fourth case, is the 39 weeks of gestational week female baby with 3 to 3.5 kilograms, hospitalized for respiratory distress start after birth. The X-ray showed the white lung with saturation of 75 to 85%. Baby intubated and surfactant applied intratracheally. Then blood gas analysis reveals us respiratory alkalosis. The physical examination revealed 3.6 systolic murmur. The echocardiography, then after they noticed the systolic murmur, the cardiac type, total anormal pulmonary venous return, the narrow PDA and ASD. The baby transferred to our center for further management and operation. It's the first hour X-ray which shows the pulmonary edema and pulmonary congestion in babies. The baby continues and we start low dose furosemide in this baby, 0.5 milligrams per kilograms per dose with 2 doses. The ventilator setting gradually decreases with diuretic dose, and baby extubated 2 days after hospitalization to us. And 7th day of hospitalization, the baby operated by congenital cardiac surgery team with total anormal pulmonary venous return repair procedures. And the 15th day postoperatively, the patient discharged without any symptoms. And I want to talk lastly the complex heart defects and rare disease. There are further complex congenital heart disease which might be associated with an acute decompensation in the postnatal period. In principle, these complex heart defects exhibit usually the same clinical picture as described critical congenital heart diseases, either with duct-dependent systemic or pulmonary perfusion. On basis of the leading symptoms, the clinician should be able to initiate the first adequate measures until a definitive diagnosis exists and a specific therapy is possible. Nevertheless, the heart defect should still be mentioned briefly, the total anomalous pulmonary venous return with obstruction. These patients are seriously ill with pronounced cyanosis and tachy and dyspnea, which can develop within the first hours of life, as our case. In addition, pulmonary edema develops rapidly, in particular when prostaglandin is applied. The clinical picture can resemble a respiratory distress syndrome and thus delay the diagnosis. The X-ray images show signs of pulmonary congestion with pulmonary edema and or lymphangiectasis. These patients cannot really be stabilized by conservative therapy measures. It's a rare defect, but it is important to not forget it when in doubt. If your respiratory distress syndrome baby does not go well with your first measures, then surely you must do the echocardiography to rule out the total pulmonary venous return anomalies. The therapy consists in the fastest possible transfer to cardiac surgery or cardiac catheter intervention. Each time delay worsens the prognosis dramatically. Thank you for your patience. Now I can take the questions.
Good day and welcome. My name is Katerina Tikhonova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of that treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника Лив, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники Лив желает вам благополучных дней.
Hello, this is Dr. Deniz Akkaya. Today, I am going to, excuse me, let me please first share my screen. Yeah. Okay. So we're going to talk about some of the skin diseases that are common in childhood. That is actually a hot topic all over the world, which is scabies, and also some vascular anomalies, which needs to be watched out for. So here is our case. This is a 3-year-old male with presenting with dry skin, redness, and itching for the past 10 months. Mom reports that she has been using topical corticosteroids, a mild potency topical corticosteroid, hydrocortisone. However, the child can't fall asleep, wakes up frequently from the sleep, so the parents aren't sleeping as well. There's no sneezing, no nasal congestion, and sometimes he reports having an itchy nose. With the family history, the mother has mild allergic rhinitis, probably due to house dust mite, and the father describes cholinergic urticaria, dermographism, and allergic rhinitis. On an external center, he was tested for specific IgE levels. They were negative, and his eosinophil levels are slightly elevated. So mom reports that the most itchy areas are his wrists, arm folds, back of the knees, the popliteal area, and she reports that his skin is red and flaky, and today is a good day. So you can see that even during the photo documentation, he couldn't stop scratching himself. His skin was all red. He had widespreadly distributed red and dry plaques, especially on the forearms, on the popliteal area, and on the wrists. So at this point, I would like to ask, what is your diagnosis and why does this condition happen? And what are your differentials? Which tests should you perform? And what are the possible comorbidities? And are there any infectious complications? And should you eliminate any foods from his diet? Do they have any causal relationship? And what would be your skin care and treatment approach? So upon these questions, I will try to talk about atopic dermatitis, which is a chronic recurrent pruritic inflammatory skin disorder. It is actually the most common chronic inflammatory disease of the childhood, and it's more prevalent in the past 3 decades. Its prevalence in childhood is approximately 20%. Luckily, most of the cases are mild and moderate. Only a very small proportion of the cases are severe cases. The onset is usually in the first months of life. We don't expect to see a presentation of atopic dermatitis lesions within the first 2 months. If there is an eczematous eruption in an infant younger than 2 months of age, then we should think about other diagnoses. Onset is usually in the first 2 to 6 months of life, and more than half of the cases present within the first year, and more than 85% of the cases are diagnosed within the first 5 years of life. There are two important risk factors for developing atopic dermatitis. One is the flagrant loss of function mutations. Flagrant is actually the protein that encodes the protein flagrin, which is very crucial in the terminal differentiation of epidermis. It is the major structural protein of the stratum corneum, and flagrin breakdown products are very important in the formation of barrier function of the epidermis. The other important risk factor is the family history of atopy. So approximately 70% of the cases have a familial history of atopy, and the risk is higher if both parents have atopic dermatitis, and maternal atopy is a greater risk factor than the paternal atopy. So why does it happen? Why does atopic dermatitis happen? When we look at the pathogenesis, it's complex. Genetics, immune system, and environmental factors they all contribute to the pathogenesis. However, atopic dermatitis is a very heterogeneous disease. There are distinct endotypes and phenotypes, and some cases may really be hard to diagnose or to keep under control. Epidermal barrier dysfunction is a topic that I would like to discuss a bit more. You can think about the epidermis as a brick and mortar model. So epidermis serves as a constant barrier that protects the body from microorganisms, environmental allergens, and irritants. The mortar is actually the lipid layer, which is consisted of the natural moisturizing factors of the skin, and half of it is ceramides, one quarter of it is cholesterol, and there's 10 to 20% free fatty acids. The bricks are actually the specialized keratinocytes known as corneocytes. And it contains flagrin proteins and a cornified envelope. So if there is a defect in the epidermal barrier, then the transepidermal water loss is increased. The penetration of allergens are increased. Also, the irritants and the microorganisms can penetrate easily from the skin. So there is a subsequent inflammatory reaction and the risk of allergic sensitization. So epidermal barrier dysfunction is known to be the primary cause of atopic dermatitis. First, there is the epidermal barrier dysfunction, and it facilitates the presence of this dysfunction, the development of other atopic diseases. Immune dysregulation is another important topic in the pathogenesis of atopic dermatitis. We know that in the acute and chronic phase of the disease, there's T helper 2 activation, and there's T helper 1 activation in the chronic phase. There are many known cytokines that contribute to, for instance, like IL-13, which is the pruritus-specific cytokine. IL-4 and 13, they stimulate the B cells, and their activation results in increased IgE production. And there are several triggering factors known as the environmental factors, which help the disease to become prominent, like rapid temperature changes and sweating. Sweat irritates the dry skin. Low humidity, excessive washing of the skin, contact with irritants such as wool. Wool is an important contact irritant for patients with atopic dermatitis. Chemicals, cosmetics, harsh soaps and detergents. Contact allergens, IRA allergens like house-like mites and pollens are important. Microbial agents such as Staphylococcus aureus, we know that the presence, the colonization of Staphylococcus aureus in atopic skin leads to exacerbation of atopic dermatitis lesions. Some foods can trigger the attacks, although it's a very low proportion. And emotional stress, as in all disorders, can be can show a negative effect. So how do we diagnose atopic dermatitis? There are no specific laboratory tests or markers for the diagnosis of the disease or to predict the severity of the disease. So the diagnosis is made clinically. The presence of pruritus, the chronic course, presence of other atopic diseases or history of familial atopy, and the typical morphology and distribution of the lesions together lead us to the diagnosis of atopic dermatitis. For the diagnosis, there are several sets of diagnostic criterion. Hanifin-Rajka criterion are the one that is used most widely all over the world. So there are 4 major diagnostic features and 23 minor diagnostic features. In order to diagnose a patient with atopic dermatitis, you need to have 3 of the 4 major diagnostic criterion and 3 of the 23 minor features. So pruritus, typical morphology and distribution of the lesions, chronic or chronically relapsing dermatitis, personal and or family history of atopy are among the major diagnostic criteria. It has, as I said, one of the major clinical diagnostic features is the typical morphology and distribution of the lesions. So it is age dependent. In infants and small children, face and the neck are involved, especially the cheeks, and the extensor surfaces of the extremities are affected. In infants and small children, there is usually acute, on skin you can see the signs of acute inflammation with exudative lesions. In older children, flexural areas, neck, antecubital and popliteal areas and wrists are involved. And in older children, you can see the signs of chronic inflammation together with lichenification. However, in all ages, xerosis or dry skin is a prominent feature of the disease. So here you can see in an older child the involvement of the popliteal areas and the antecubital folds. And the differential diagnosis is so broad. Atopic dermatitis has several mimickers. Among them, seborrheic dermatitis is maybe one of the most common ones. In seborrheic dermatitis, it usually presents in younger children, like within the first 2 months of life. We know that atopic dermatitis doesn't present itself in the first 2 months of life. Allergic or irritant contact dermatitis can be in the differential, however, can be concomitant with atopic dermatitis. Nummular eczema and psoriasis are among the chronic dermatoses that are listed in the differentials of atopic dermatitis. Among hereditary disorders, several forms of ichthyosis, because they present with dry skin, is in the differentials, especially Netherton syndrome. Some of the infections, especially scabies and some dermatophyte infections like Tinea corporis, can mimic atopic dermatitis. Very rarely, malign disorders like mycosis fungoides or Langerhans cell histiosis are in the differentials. There are some rare immunologic disorders. However, if there is a severe atopic case with recurrent infections, we must include the immune deficiency syndrome in our differential diagnosis, like Wiskott-Aldrich syndrome, severe combined immune deficiency, hyper-IgE syndrome, and DiGeorge syndrome. And some metabolic disorders can present with eczematous lesions, including zinc deficiency and acrodermatitis enteropathica. So if the clinical diagnosis is not definitive, sometimes we can perform skin biopsies, we can check serum IgE levels, we can do mycological testing like potassium hydroxide testing, patch testing or genetic testing in order to exclude or rule out the other conditions that can mimic atopic dermatitis. As I've said before, infantile seborrheic dermatitis is an important mimicker. Sometimes they overlap. Sometimes in the first 2 months, the baby has seborrheic dermatitis. In infants with severe seborrheic dermatitis in the early life, they tend to develop, again, a severe atopic dermatitis. So seborrheic dermatitis involves the axillary area and the diaper area. In atopic dermatitis, we don't expect to see axillary lesions. The arms can be affected in atopic dermatitis. However, seborrheic dermatitis involves the axillary folds. And we don't expect to see any diaper area involvement in atopic dermatitis. However, seborrheic dermatitis can involve the diaper area. And an important distinctive feature is that seborrheic dermatitis is not pruritic, it's not itchy. Allergic contact dermatitis may be in the differentials. However, it can be a triggering factor that exacerbates atopic dermatitis. So in cases that are resistant to treatment, two important conditions are important to consider. As I said, immune deficiency syndromes and nutritional and metabolic disorders like acrodermatitis enteropathica. Studies from the non-lesional skin of atopic dermatitis patients revealed that the common changes in the lesional skin are also present in non-lesional skin, including the increased epidermal water loss and the inflammatory changes. So today, atopic dermatitis is considered a systemic disease. Atopic dermatitis has many comorbid diseases. One of them is the very well-known atopic march. A good proportion of patients with atopic dermatitis can develop asthma, food allergies, or allergic rhinitis. Pruritus is the most common symptom. It causes a significant impairment of quality of life of the infants and their families. So it has a negative impact on falling asleep or staying asleep. It results in decreased rapid eye movements period of sleep, so which causes behavioral changes on the kid. So patients with severe atopic dermatitis, they tend to have attention deficit hyperactivity disorder, depression, and anxiety. And this risk increases with the early onset and severe disease. And an important thing to consider is that adolescents with severe atopic dermatitis has suicidal ideation, which is a pretty high rate. Atopic dermatitis has also infectious complications and comorbidities, like many of the patients have staph aureus colonization, and the viral infections are more widespread in atopic patients, including herpes simplex, enterovirus infections, and Coxsackie infections. So impetigo is a very common complication of atopic dermatitis. As I said, it's usually with staph aureus. The honey-colored crusts are so characteristic of impetigo. Herpes simplex infections can be generalized. In this case, it is called eczema herpeticum or Kaposis verrucoliform eruption. The same condition can occur with hand, foot, and mouth disease, and that condition is a recently described condition known as eczema coxsackium. It's usually together with Coxsackie A16. Scabies is an important differential diagnosis. However, atopic dermatitis patients can develop severe scabies lesions, and molluscum contagiosum lesions are more widespread in patients with atopic dermatitis. How about within our case? I had a question: should you eliminate any types of food from his diet? How about the relation of atopic dermatitis with food allergies? Well, children with AD are at risk for developing food allergies, including anaphylaxis. It can be life-threatening. So it may be a good chance to discuss with the families to what to do in case of any emergency condition like angioedema or anaphylaxis, maybe even to prescribe an adrenaline autoinjector. However, like 85% of infants with atopic dermatitis don't have food allergies. It's not that common. And if there's a food allergy, it's most of the time to milk, egg, peanut, wheat, and soy. In cases with atopic dermatitis, the food allergy reactions are not always eczematous lesions. They're most of the time type 1 hypersensitivity reactions like urticaria, contact urticaria, or non-skin symptoms like GI symptoms, wheezing, or nasal congestion. There was the LEAP study, which was published in 2013, is the LEAP study. It was a huge game changer. So with the LEAP study, it was shown that infants in whom peanut were introduced in early life, they had a significantly lower incidence of clinical peanut allergy. So elimination diets does not have a protective effect on the development of food allergies. So epidermal barrier dysfunction is actually associated with the development of food allergies in early infancy because of the disrupted epidermal barrier. And the severity of atopic dermatitis is directly correlated with the risk of development of other atopic diseases like asthma and allergic rhinitis, and also food allergies. In most atopic dermatitis cases, though, if you test them with skin prick tests or specific IgEs, you would find many positivities for foods or aeroallergens. However, this just shows sensitization. It doesn't prove a clinically relevant allergy or a causal relationship. So screening tests and random skin prick tests are not recommended for detection of food allergies. If there is a good and reliable history for a specific food, then those should be tested. So together, today, strict elimination diets are not recommended for cases with atopic dermatitis because that elimination may facilitate the loss of food tolerance and the occurrence of more severe type 1 IgE-mediated reactions. How about the treatment? How should we treat our patient? We should always educate our patients and their families that there is no cure. This is a chronic condition. However, the objective of the treatment is the control of the acute attacks, prolong the periods of remissions, and maybe to prevent the development of treatment-related side effects and to prevent the development of comorbid diseases. So there are several treatment guidelines for the treatment of atopic dermatitis. In all of the guidelines, patient education or parental education is the key step. So we should discuss the chronic nature of the disease, the importance of the treatment adherence, and appropriate use and application of topical therapies. Skincare is the second important step in treatment with regular bathing, regular and liberal use of emollients or moisturizers. Topical corticosteroids are still the mainstay of anti-inflammatory treatment. Topical calcineurin inhibitors, and in severe cases, systemic immunosuppressive agents like cyclosporin or biologic agents like dupilumab can be used. There's also the need for adjuvant therapies, like in case of bacterial infections, appropriate treatment should be prescribed, but always we don't ever prescribe like antibiotics without culturing the patients. Diluted bleach baths, I'm going to talk about it, are really helpful in controlling the bacterial infections. In case of viral infections, antiviral therapy should be prompted. And for sleep disturbances, systemic antihistamines, especially the first generation ones, can be helpful. Also, wet wrap therapy is an important adjuvant therapy in addition to diluted bleach baths. What should be the atopic skincare? As I said, it's one of the mainstays of treatment. So we recommend our patients to take daily showers for 5 to 10 minutes, not longer. The purpose of the daily showers is to clean and to moisturize the skin. It also helps the debridement of the infected skin and increases the absorption of topical treatments. It's called as the soak and smear method. The use of, instead of regular soaps or harsh cleansers, the use of Syndex or soap substitutes that are suitable for sensitive skin should be applied at every shower for their antibacterial effect. And application of appropriate moisturizers or medications after quickly pat drying the skin after the shower within the first 3 minutes is crucial. Petrolatum is a good and cheap alternative of the modern moisturizers, but it has no water effect content, so it's only effective when applied after bathing. And frequent and liberal application of the modern moisturizers should be done during the day. And of course, if there are any proven allergens, they should be avoided together with the possible irritants. Dilute bleach baths, it's recommended in all treatment guidelines, in the European and the North America guidelines and the Japan guidelines. In some studies, it's not shown to be superior to regular bathing. However, it probably has a good antimicrobial effect, anti-inflammatory properties, and antipyretic effect. So it spares the topical corticosteroid use. And it causes an important decrease in disease activity scores. So in case of bacterial infection, it could be applied together with intranasal mupirocin, and it can be used as a prophylactic measure in cases with recurrent bacterial infections. Wet wrap therapies is basically, again, it's recommended in all treatment guidelines. Practically, we apply the medication or the moisturizer and then cover the skin with moist bandages or moist clothes. So it really helps to treat acute flare-ups of the disease. This is a demonstration of a baby in whom wet wrap therapy is performed. You see the medications and moisturizers are applied, and then there's this moist bandage. Then he's covered with a long john pajama and covered with a blanket. And he can stay like this overnight. Back to our case. This case, of course, was treated with topical treatments, only a mid-potency corticosteroid methylprednisolone for a week, and application of wet wrap therapy together with diluted bleach baths. And after 10 days, you can see that without scratching himself, he can stay calmly, like looking at his phone. So before at another center, he was recommended a strict elimination diet. So we opened his diet. He can eat anything, no severe reactions. And with the topical treatment and atopic skincare, he became, the acute flare-up was treated. And with the application of moisturizers and keeping the atopic skincare, he was free of acute attacks for a prolonged time. Among the systemic treatments, we have some new agents like biologic treatments, including dupilumab, which is the first developed and studied biologic agent for treatment of atopic dermatitis. It inhibits IL-4 and 13 signaling, which are important cytokines in the pathogenesis of atopic dermatitis. And it's now approved from 6 years and above in the United States. So no tests are necessary before or during the treatment. We start with an induction dose and repeat the injections within every 2 weeks. It's administered subcutaneously. Cyclosporin, however, is still our first systemic choice. If unresponsive, then we can switch back to dupilumab. Let me remind you that systemic corticosteroids in treatment of atopic dermatitis is reported as outdated because after stopping the treatment, cessation of the treatment, the patients faced with severe flare-ups. So our best options are maybe cyclosporin and dupilumab at this time. So, done with atopic dermatitis. Here is another case. She's an 18-month-old girl. Mom states that she has severe itching for the past 4 months, and she was diagnosed as having atopic dermatitis by her primary care physician, and she was treated with topical corticosteroids but showed no response. On exam, with a quick look, you can see that there's a polymorphic eruption, like there is a nodule, there are nodules and some papules and some excoriated areas, widespread, especially on the axillary area. Could it be atopic dermatitis? Atopic dermatitis most commonly doesn't affect the axillary area, so that is a good hint. The patient probably doesn't have atopic dermatitis. So we keep examining her. When I put my dermoscope on the skin, I saw this sign and also this sign. So this is, I'm not sure if you can see it, but this is like a delta jet. And also this looks like the clouds beyond the jet. We'll talk about that. When I scrape the skin, I see a visitor living within the epidermis. So it's the sarcopte itself, its egg, and also its scabala. So at this time, what is your diagnosis? Why does this condition happen? What tests should you or would you perform? Are there any infections complications of this condition? And what would be your treatment approach? So, hot topic all over the world during the COVID-19 pandemic. There are several cases of scabies reported all over the world. It is an ectoparasite infestation. So, Sarcoptes scabiei varhominis is a host-specific mite. It lives its entire life cycle within the human stratum corneum. It's a very small mite. It hatches, it lays 3 eggs per day, and the eggs hatch in 2 to 4 days. This is important for our treatment decisions. Transmission, as we all know, is with close contact with an individual, infected individual or patient. It can affect all age groups, including the newborns, all socioeconomic groups, but it's more common in women and children. And it's more common in immunosuppressed individuals. Incubation period is 4 to 6 weeks. However, if the patient was sensitized before to the mite, then the symptoms may appear in 1 to 2 days after the contact. So it's a little bit similar like allergic contact dermatitis. First you need the sensitization period, and then you see the lesions. So diffuse polymorphic pruritic eruption is the hallmark of the disease, and nocturnal pruritus is very well described in scabies, but we should all keep in mind that very rarely asymptomatic infestation may occur. So treatment of all household members is crucial in treatment of scabies. What do we see on exam? Where should we look for the specific lesions of scabies, like axillary area, areola, periumbilical area and the waistline, inguinal area and the genitals and the knees, flexures of the wrists and finger webs are important. Also, the buttocks are common areas where we can find both the eczematous changes and where we can find the burrows. Axillary and inguinal areas are the areas where we can find the scabies nodules. Here you see an infant with several nodules on the axilla. And keep in mind that in infants, in small infants, scalp and the face can also be affected. So topical treatment should be applied to face and scalp in small infants. And the palmoplantar areas and axilla are important areas to look for vesicles, pustules, or nodules. So burrows are the typical lesions of specific primary lesions of scabies. They're 1 to 10 millimeter linear lesions. They are found on especially acral areas like the interdigital areas, the wrists and the elbows. When you put your dermoscopy on a burrow, you would see the specific delta jet, wing jet with its contrail. So that was the image I was showing you previously. I have already mentioned asymptomatic carriers due to the possibility of the asymptomatic carriers. The whole household members should be treated simultaneously. And there's a risk for secondary infection, especially in infants with Streptococcus pyogenes. Post-streptococcal glomerulonephritis is not uncommon in infants with scabies. So if there is a secondary bacterial infection of the skin, it should be treated with appropriate antibiotics. How about the treatment? Well, permethrin cream is still the first choice. It can be applied to infants older than 2 months of age. It should be applied to clean and dry skin. Should be applied all over, including the face and the scalp. Should be left for at least 12 hours and then rinsed off, and should be repeated after 7 to 10 days, maybe 2 or better 3 times. Lindan may have CNS, has the risk of potential CNS toxicity, so it's not preferred, and also resistance is very common. Chromation lotion is sometimes used. Sulfur, precipitated sulfur ointments are very effective. They can be used in 5 to 10% concentrations. It has a very good efficacy. It should be applied overnight for 3 successive days and should be repeated after 10 days. And ivermectin is another systemic or topical option for treatment of scabies. Oral ivermectin, systemic ivermectin, is appropriate for kids weighing more than 15 kilograms. However, with studies, it's shown that in smaller infants who are less than 15 kilograms, ivermectin is still safe, but it's off-label at this time. Another case is a 1-month-old baby girl. There's a red stain on the preauricular and the neck area. It was first noticed 10 days ago, so at 2nd or 3rd week of life. What is your diagnosis? What are the potential complications? Should you treat it or leave it? And if you treat it, what's the treatment of choice? Another case, a 1-month-old baby girl with pink patches on the face, on the globular area, on the eyelids, on the tip of the nose, and on the philtrum. And these lesions are present since birth. So what is your diagnosis considering the localization of the lesions, and what is the course of this condition? Another case, a 4-month-old baby girl, there is a red stain on the face since birth. And in this case, what is your diagnosis? What are the possible associations? And what would be your treatment approach? So those were 3 vascular lesions that we're going to discuss about. Vascular anomalies are actually common. However, they present in a wide spectrum, and there are a large number of similar conditions with distinct findings and clinical associations with different prognosis. So it's important to make a correct diagnosis. There is unfortunately a confusion in terminology. please refer to ISWA website for the classification of vascular anomalies in case you need it. They are separated into two main groups, including the tumors and malformations. Angioma and hemangioma should not be used alone. Like if we are referring an infantile hemangioma, then we should refer it as an infantile hemangioma. And the term hemangioma should not be used for lesions, vascular lesions in adults, except for non-involuting congenital hemangioma. And cavernous hemangioma is again an outdated term which represents deep infantile hemangiomas. We're going to talk about them. With the advances in genetics, we know the role of PIK3CA and RAS-MAP kinase pathways in vasculogenesis, and discoveries of gene mutations that lead to vascular anomalies are now described. And with the accurate terminology, we can make an accurate diagnosis, and we can start pertinent treatment, and we can prevent or treat the complications. So terminology is important. This is a complicated and busy slide, but as I mentioned, with the advances of genetics, we know that very common vascular anomalies, including pyogenic granulomas, venous malformations, or arteriovenous malformations are caused by mutations in these pathways, which is important in cell proliferation, survival, morphogenesis, and maturation of the cells. So you can find the ISWA classification online. This is the latest revision in May 2018. Probably it's going to be renewed next year with the advances in genetics. So vascular anomalies are divided as tumors and malformations. Among the top tumors, there are benign ones, locally aggressive ones, and malignant ones. Of course, the most common benign vascular tumor is the infantile hemangioma. Congenital hemangiomas, tufted angiomas, and pyogenic granulomas are other common benign vascular tumors. Among the locally aggressive ones, you can see capusiform hemangioma. You can see the mutations leading to these conditions right next to them. In capusiform hemangioendothelioma, there is the risk for Kasabah-Merritt phenomenon. An accurate diagnosis, as I said, can help you to control the possible complications. So, infantile hemangiomas are the most common tumors of infancy. They are benign vascular tumors derived from the endothelial cells. It's present in 5% of the newborns. However, it's more prevalent in preterm infants. The important thing is for the differential diagnosis is it's not present at birth. Maybe you can see its precursor like a pink patch. However, the lesion is not fully developed at birth. So if there's a fully developed vascular tumor, it's probably a congenital hemangioma or other benign or malignant vascular tumors. So it presents within the first, second, or third week of life. It's not present at birth. Depending on the location of the depth of the tumor, it is categorized as superficial, which is the most common form, or deep, like you can see here on the eyelid, or the mixed type. You can see the deep bluish portion of the infantile hemangioma, and you can see the red, bright red, superficial portion of the hemangioma. And also there is this reticular or hemangioma with minimal growth phenotype, which can be easily confused with capillary malformations. According to the distribution pattern, it could be focal, like this one. It can be multifocal, like you can see tens of small infantile hemangiomas distributed all over the body. It can be segmental, like this one or this one, or it can be indeterminate. What's the importance of segmental infantile hemangiomas? Well, especially if located on the face, facial area, there's the risk for face syndrome, which includes posterior fossa malformations, arterial abnormalities, cardiovascular abnormalities, eye abnormalities, and sternal clefting. If an hemangioma is located segmentally on the sacral area or the pelvic area, it can be accompanied by lumbar syndrome with urogenital anomalies and several other developmental abnormalities. Infantile hemangiomas have a specific growth pattern, which is really important in diagnosing the cases, because most of the time the diagnosis is made clinically. So as I said, it's not present at birth. It shows an early rapid proliferation, which is most rapid in the 5th or 7th week of life. And then it shows a late slow proliferation, then shows a plateau phase, and starts to involute. So at 4 years of age, 80% of regression is usually completed. At 4 months of age or 5 months of age, 80 or 90% of the growth is completed. And the involution starts after 1 year of age. So this specific growth pattern really helps us diagnose the patients. However, there are some myths about infantile hemangiomas. You can hear our colleagues calling them, like, just wait and see, it will go away on its own. Treatment is not necessary. This is the number one myth. It goes away without leaving a scar. It will go at 1 year of age. No, it doesn't go away at 1 year of age. At year 4, 80% of the regression is completed. In most cases, it can complete its regression at 10 years of age. So complications are very rare. Don't worry about it. These are all myths about hemangiomas. There was, again, a big game changer study that was published in New England Journal of Medicine in 2008. And after this case series, there were several multicenter studies, and now oral propranolol therapy is a treatment of choice for complicated infantile hemangiomas, which has FDA and EMA approval. So we're now living at the propranolol era, and at this era, which infantile hemangiomas should be treated and when should be the treatment started? Those are two important questions that I will try to answer. So what's the optimal timing for treatment? Infantile hemangiomas are heterogeneous, so there's no one-size-fits-all approach. It doesn't work. Lesions are difficult to predict, so it depends on the size, location, pattern, distribution, and depth of the lesion. Lesions are first noticed at the 2nd or 3rd week of life. However, dermatology referrals are approximately at 5 months. At this time, at 5 months of age, 95% of the growth of the lesion is completed. Infantile hemangiomas are time sensitive, so treatment should be started at the right time to prevent the complications and to prevent the further growth of the lesion. So optimal time for referral and treatment decision is the 4th week of life. So at 1 month of age, infants with infantile hemangioma should be referred to pediatric dermatology clinics. And also all vascular anomalies that show any change in the first 2 months of life should also be referred to vascular anomaly centers. So treatment should be started before 3 months of age, optimally at 1 month of age, to prevent the further growth of the lesion by interfering the proliferation. High-risk cases should be treated. That includes the risk for permanent disfigurement, especially the lesions that are located on the face, especially on the midline, like the lips or tip of the nose, ears or periorbital lesions. Hemangiomas that compromise the vital, that could potentially compromise the vital functions like visual, feeding, or respiratory functions, the potential for ulceration, segmental hemangiomas, and more visceral, most of the time hepatic infantile hemangiomas should be treated. Ulcerated hemangiomas, like this one, can compromise the vital functions, can cause residual scarring and disfigurement. The residual changes are seen in more than half of the cases, and the residual changes are most common after the involution of the mixed type hemangiomas, and they're most commonly telangiectasias or fibrofatty tissue or anotoderma. Involution doesn't mean normal skin. Post-involution scala is an important topic to consider. And since like 60% of the hemangiomas are located on the head and neck region, they can lead to social stigmatization. So the early treatment of facial lesions is crucial. Hemangiomas are recently, this is a very good literature that is found on the pediatrics journal website. I would recommend all of you to read it. So they stratified the hemangiomas as very high risk hemangiomas. So if there is a face and scalp hemangioma more than 5 centimeters in diameter, or a segmental hemangioma, especially the bird area, the face syndrome risk. If there's a paraocular hemangioma with potential eyelid asymmetry, ptosis or proptosis, or if there's a segmental lumbosacral or perianal large or segmental hemangioma, or if there are multifocal hemangiomas, more than 5 on the skin, it can help predict us the presence of hepatic hemangiomas. They should be referred urgently to pediatric dermatology clinics within a week or so. Because of their risks, treatment should be started as soon as possible. Hemangiomas with high risks are smaller hemangiomas on the face, like less than 2 centimeters, on the neck and scalp, oral lesions, breast lesions, and large extremity lesions. And these require fast referral to pediatric dermatology clinics within 2 weeks. So treatment should be started within 2 weeks. So, as I said, oral propranolol is the treatment of choice for hemangiomas requiring systemic treatment. In a small proportion of the cases, systemic corticosteroids can be started together with oral propranolol. Only in hemangiomas less than 1 millimeter in thickness can be treated with topical beta blockers, with so to say topical timolol. And some hemangiomas can be treated with local treatments, most commonly pulse dye laser treatments. How do we start oral propranolol in practice to small infants? Well, previously we used to be very cautious. We were not very experienced in treating small infants with oral propranolol, but this is now the 13th year of oral propranolol in treatment for infantile hemangiomas. So we've all gained experience with the agent, and we know their its side effects, and we know how to control them. So I would again refer to the journal, the literature on pediatrics on how to start oral propranolol therapy for small infants. So this is one of, these are my cases. You know, oral propranolol is effective. in the early proliferative phase. This is an hemangioma which could easily, without treatment, lead to cranial deformity of the nose. Together with oral propranolol and pulse dye laser treatment, the lesion shows almost complete resolution at 10 months of age. After the proliferation phase, oral propranolol is still effective. This patient had developed astigmatism because of its effect on the visual acts. So he was treated, she was treated by the ophthalmology department for the correction of the astigmatism. And with oral propranolol, you can see the lesion has regressed significantly. And now she has a good eyesight too. Again, another patient treated, it's an ulcerated combined hemangioma on the tip of the nose, which is a high-risk lesion. In treatment in such cases should be started within 1 week or so. You shouldn't wait. And so you can see the results of oral propranolol therapy together with laser therapy, but still she needed some surgical correction for the remaining fibrofatty tissue. If this patient was started oral propranolol at 1 month of age, probably this cranial deformity could be prevented. In thin hemangiomas, like less than 1 millimeter of thickness, topical timolol can be very effective. However, keep in mind that it's off-label, and topical timolol is 20 times more potent than oral propranolol in its beta blockage activity. So side effects may occur if it is applied to large areas of the skin because of the systemic eruption. The studies have shown that when applied on larger areas of the skin, it's absorbed from the skin systemically, and it can cause side effects through beta blockage. Perianal area is an important area. It can easily get ulcerated. So the diaper area should be, any hemangioma on the diaper area should be treated. So this is a patient, I started topical timolol at 2 months of age, and you can see at the age of 2 years, there is just residual telangiectasias because it doesn't cause any cosmetic concerns on the perianal area. Laser treatment is not necessary in this case. However, if this lesion was on the face, I would definitely treat this area with laser in order to make the residual telangiectasias go away. So when we treat hemangiomas with lasers, the treatment of choice is pulse dye laser, which is specifically developed for vascular lesions. It's indicated for treatment of ulcerated hemangiomas and the treatment of residual changes and telangiectasias. So in the beta blocker era, laser should be used for only these 2 indications. Here is a patient of mine. This is the diaper area. It was ulcerated. It was left untreated by the primary care physician. It's also infected. The culture showed E. coli growth. So she was treated concomitantly with oral antibiotics, topical antibiotics, and laser therapy. So you can see the results. Of course, she was started then with oral propranolol, and she became a healthy baby. Another case, facial lesions, especially when large or ulcerated, should be treated as soon as possible. This is another case which I treated with laser and oral propranolol for a prolonged time. Each time we try to stop the treatment. We usually treat patients for 6 months or so. She showed rebound growth. So she's now 4 years old, and she's still on propranolol. And this is another case with face syndrome. You see an segmental infantile hemangioma located on the forehead and eyelid involving the scalp. She was treated with oral propranolol, and after a year or so, she was treated with pulse dye laser for the treatment of residual telangiectasias. So some studies show that combination combination treatment with infantile hemangiomas with oral propranolol and pulse dye treatment, laser treatment, results in faster and more complete resolution and a less cumulative propranolol dose. And in accordance with the literature, that's my personal experience. This is the 5th week of the patient. You see that in a month, the patient was, that was the first years, it was 2009 or so. So until we started oral propranolol therapy, he quickly got ulcerated at 2 months of life. So it took several laser sessions to heal the ulceration and to heal the scarring. So I will pass on this. For treatment summary, if for infantile hemangiomas, if there's potential for life-threatening complications, if there is a possibility of accompanying syndromes or anomalies, if there is a possibility that would lead to loss of vital functions or a possibility of permanent deformity or ulceration, those are called complicated hemangiomas, and they should be treated, and the risk stratification should be made at 1 month of age. And when treatment is indicated, then our treatment of choice is oral propranolol, and topical tominolol can be used as off-label treatment in selected thin infantile hemangiomas. Lasers and surgical treatments are effective in post-involution residual changes, and combination systemic therapies like oral propranolol and systemic corticosteroids can be administered in selected cases, and lasers can be started simultaneously. Laser treatment can be started simultaneously with oral propranolol treatment in selected cases. So this was that case, 1-month-old baby. You can see this is after 2 weeks. This lesion, it's at the bird area, which is a high-risk area. You can see how enormously it grows within 2 weeks. So this is a very high-risk hemangioma, and if the treatment had been started within the first week, probably she wouldn't develop this large tumor. So our diagnosis is a combined high-risk infantile hemangioma of the bird area with potential risk for airway compromise, and oral propranolol, maybe together with systemic corticosteroids, should be started as soon as possible at the newborn period. So the other group, other than tumors, of vascular anomalies is vascular malformations. They are named after the type of the vessels they are composed of. The most common ones are capillary malformations. And capillary malformations are divided into several groups. First one is nevus simplex, or angel kiss, or stork bite, or salmon patch. The second one is cutaneous or mucosal capillary malformations, aka port wine stains. There are different subtypes of capillary malformations, like it could be together with syndromes, it could be together with overgrowth syndromes, it could be together with microcephaly or megaloencephaly, it could be together with AVMs, and also other forms of telangiectasias are among the simple capillary malformations. So nevus simplex is not a true malformation. It just represents persistent fetal circulation. It's present in more than half of the newborns. It is a temporary capillary malformation. It's located on the midline. It presents as a pink pale macule or patch, which is not very well circumscribed, may darken with crying or internal pressure increases. Frontal area, glabellar area, eyelids, philtrum, nose are the areas that it's usually located. It can be sometimes generalized, and this is known as the nevus simplex complex. If there are other signs of spinal dystrophism, like a tail or any other dysmorphic feature, patients should be evaluated with a lumbosacral MRI in order to diagnose spinal dystrophism. So this case that I mentioned previously is actually a case of nevus simplex. What is the course of the condition? It will go away on its own at the first or second year of life. Sometimes they can be persistent. So after 18 months of age, if it's still persistent and if the family is worried about the condition, then it can be treated easily with pulse dye laser. Most of my patients need just one session of laser treatment, then it fades away completely. Some patients may require 2 or 3 sessions of laser therapy. Port wine stains or cutaneous or mucosal capillary malformations, they are present at birth, like nevus simplex. They're present in 0.5% of all newborns, and they're most commonly located on the face and neck. They're well circumscribed in contrast to nevus simplex. They present as unilateral macules or patches that doesn't cross the midline. The color ranges from pale pink to purple. It is actually the ectatic capillaries located on the superficial dermis, and we know that now they result from mutations in GNAQ gene. They actually show a progressive course. With aging, the lesions tend to darken, become deeper purple, and thicken. And sometimes vascular blebs may develop on the surface of the lesions. Is treatment necessary? Well, in a study with 230 patients, more than 60% of the patients told that their life would change dramatically if the stain would disappear. So to prevent the psychological impact of the lesion, preferably the lesion should be treated before 2 years of age, before the patient becomes self-aware of the lesion, to prevent social stigmatization. So how do we treat them? There are several lasers or wavelengths that are affected in vascular lesions. However, the gold standard of treatment is the 595 nanometers pulse dye laser. It's the gold standard treatment of vascular lesions, especially for capillary malformations. And what is the timing of the treatment? Again, as soon as possible. We know that the studies have shown that pulse dye laser is safe in the infantile period, and it shows a higher efficacy in the early life because the presence of hemoglobin F, because the vessels are less dilated in early life, because in a young infant, the interaction of the presence of melanin is low, so the interaction of the laser energy with melanin is lower, and because the skin of the newborns or infants is thin, it becomes thicker with the increasing age. There is a very good study published in JAMA Dermatology. So these are the cases, approximately 200 patients, infants, approximately the treatment was started at 3.3 months of age. There was no scarring or permanent pigmentary changes after the treatment. We know the treatment is effective and safe in the infantile period. And for the facial lesions, especially for the facial lesions, as many sessions as possible should be performed without the need of general anesthesia in the first year of life. So you can see the results of port wine stains treated with pulse dye laser. This is the result after 4th session. This is the results after 7 sessions. In general, extremities, distal extremities are more resistant to laser treatment than the truncal or facial areas. So this was our case, 4-month-old baby girl. What is your diagnosis? This is a facial capillary malformation or a port wine stain. What are the possible associations? Would you expect to see any syndromic association, like if it would be located maybe somewhere else on the face? It could be associated with Sturge-Weber syndrome. However, in this case, we don't expect any syndromic associations. And our treatment approach would be to treat this patient with pulse dye laser for several sessions. I have already mentioned Sturge-Weber syndrome. So again, it is due to GNAQ mutations. It's the presence of facial and leptomeningeal capillary malformations with possible eye abnormalities like glaucoma or bony or soft tissue overgrowth. The risk is associated with the location of the port wine stain. So large and bilateral lesions, especially on the frontal area, poses a risk for Sturge-Weber syndrome. There are several other syndromes that were described with their causative mutations. So I would recommend you to have a look at the ISPA website if you have relevant cases. Klippel-Trenaunay syndrome is another syndrome with lower extremity capillary malformation, venous malformation, and extremity overgrowth. The lymphatic malformation may be present at birth or may become apparent later in life, and it shows a progressive course. Lymphedema may be present as well. So these cases can be treated now as off-label treatment with rapamycin for prolonged periods of time. So in summary, all vascular lesions should be carefully evaluated for differential diagnosis and possible syndromic associations. And all vascular lesions that change in the first 2 months of life should be referred to experienced vascular anomaly centers, like we have one at Vadi Live Hospital. We're a good team with our radiologists and hematologists and me, myself. And we know that lasers are safe in the pediatric age group and better results can be achieved with early treatment. First treatment option for port wine stains is the pulse dye laser treatment, and it's more effective when started early in life in the infantile period. It wouldn't go away on its own. It would just become thicker and thicker or darker and darker with aging. And for complicated infantile hemangiomas that require therapy, the treatment of choice is oral propranolol. And I think now that was it. I thank you for your patience. And if you have any questions, I would be happy to answer them. Thank you and bye. So I don't see any questions. You can either open your microphone or you can type into Q&A area or the chat area that are on the lower band of the screen. So if there are no questions, I would like to thank you for listening, and I would like to thank all the other panelists for their contributions.